22q13 deletion syndrome, Wikipedia article audio. 22q13 deletion syndrome is a genetic disorder caused by deletions or rearrangements on the Q terminal end of chromosome 22. Any abnormal genetic variation in the Q13 region that presents with significant manifestations typical of a terminal deletion may be diagnosed as 22q13 deletion syndrome. 22q13 deletion syndrome is often called Phelan-McDermid syndrome. There is disagreement among researchers as to the exact definition of 22q13 deletion syndrome. The Developmental Synaptopathies Consortium defines PMS as being caused by SHANK3 mutations, a definition that appears to exclude terminal deletions. The requirement to include SHANK3 in the definition is supported by many, but not by those who first described 22q13 deletion syndrome. A prototypical terminal deletion of 22q13 can be uncovered by karyotype analysis, but many terminal and interstitial deletions are too small. The availability of DNA microarray technology for revealing multiple genetic problems simultaneously has been the diagnostic tool of choice. The falling cost for whole exome sequencing and, eventually, whole genome sequencing, may replace DNA microarray technology for candidate evaluation. However, fluorescence in situ hybridization tests remain valuable for diagnosing cases of mosaicism and chromosomal rearrangements. Although early researchers sought a monogenic explanation, recent studies have not supported that hypothesis. Signs and symptoms. Cause. Affected individuals present with a broad array of medical and behavioral manifestations. Patients are consistently characterized by global developmental delay, intellectual disability, speech abnormalities, ASD-like behaviors, hypotonia, and mild dysmorphic features. Table 1 summarizes the dysmorphic and medical conditions that have been reported in individuals with PMS. Table 2 summarize the psychiatric and neurological associated with PMS. Most of the studies include small samples or relied on parental report or medical record review to collect information, which can account in part for the variability in the presentation of some of the presenting features. Larger prospective studies are needed to further characterize the phenotype. Table 1. Dysmorphic features and medical comorbid conditions that have been reported in individuals with Phelan-McDermid syndrome. Table 2. Psychiatric and neurologic manifestations associated with Phelan-McDermid syndrome. Various deletions affect the terminal region of the long arm of chromosome 22, from 22q13.3 to 22q-ter. Although the deletion is most typically a result of a de novo mutation, there is an inherited form resulting from familial chromosomal translocations involving the 22 chromosome. In the de novo form, the size of the terminal deletion is variable and can go from 130 kb to 9 mb. Deletions smaller than 1 mb are very rare. The remaining 97% of terminal deletions impact about 30 to 190 genes. At one time it was thought that deletion size was not related to the core clinical features. That observation led to an emphasis on the SHANK3 gene, which resides close to the terminal end of chromosome 22. Interest in SHANK3 grew as it became associated with autism spectrum disorder and schizophrenia. Since then, 12 other genes on 22q13-CHKB, SCO2, SBF1, PLXNB2, MAPK12, PANX2, BRD1, CELSR1, WNT7B, TCF20 have been associated with autism spectrum disorder and/or schizophrenia. Some mutations of SHANK3 mimic 22q13 deletion syndrome, but SHANK3 mutations and microdeletions have quite variable impact. Most mutations do not reflect loss of the entire gene. This has been observed in mice, where deletion of both SHANK3 genes produced a weaker phenotype than many mutations. That is, in some cases the complete absence of SHANK3 protein has less impact than heterozygous SHANK3 mutations. Some of the core features of 22q13 deletion syndrome are dependent upon deletion size, and do not depend on the loss of SHANK3. As noted above, the distal 1 MB of 22q is a gene-rich region. There are too few clinical cases to statistically measure the relationship between deletion size and phenotype in this region. SHANK3 is also adjacent to a gene cluster that has a high probability of contributing to ASD, suggesting the effects of SHANK3 deletion may be indistinguishable from other genetic losses. A landmark study of induced pluripotent stem cell neurons cultured from patients with 22q13 deletion syndrome shows that restoration of the SHANK3 protein produces a significant, but incomplete rescue of membrane receptors, supporting both a substantial role for SHANK3 and an additional role for other genes in the distal 1 MB of chromosome 22. Diagnosis and management. There is an interest in the impact of MAPK8IP2 in 22q13 deletion syndrome. MAPK8IP2 is especially interesting because it regulates the balance between NMDA receptors and AMPA receptors. The genes SULT4A1 and PARV may cause 22q13 deletion syndrome in cases of more proximal interstitial and large terminal deletions. There are about 187 protein-coding genes in the 22q13 region. A group of genes CYB5R3, FBLN1, NUP50, C22ORF9, KIAA1644, PARV, TRMU, WNT7B and ATXN10, as well as MICR ornas may all contribute to loss of language, a feature that varies notably with deletion size. The same study found that macrocephaly seen in 22q13 deletion syndrome patients may be associated with WNT7B. FBLN1 is responsible for synpolydactyly as well as its contribution to the neurological manifestations. Table of protein coding genes involved in 22q13 deletion syndrome. Underline identifies 13 genes that are associated with autism. Bold identifies genes associated with hypotonia. Search for hypotonia in the OMIM database. Epidemiology. 1. Clinical genetics and genetic testing. Genetic testing is necessary to confirm the diagnosis of PMS. A prototypical terminal deletion of 22q13 can be uncovered by karyotype analysis, but many terminal and interstitial deletions are too small to detect with this method. Chromosomal microarray should be ordered in children with suspected developmental delays or ASD. Most cases will be identified by microarray, however, small variations in genes might be missed. The falling cost for whole exome sequencing may replace DNA microarray technology for candidate gene evaluation. Biological parents should be tested with fluorescence in situ hybridization to rule out balanced translocations or inversions. Balanced translocation in a parent increases the risk for recurrence and heritability within families. Clinical genetic evaluations and dysmorphology exams should be done to evaluate growth, pubertal development, dysmorphic features, and screen for organ defects. History. 2. Cognitive and behavioral assessment. Notes. All patients should undergo comprehensive developmental, cognitive, and behavioral assessments by clinicians with experience in developmental disorders. Cognitive evaluation should be tailored for individuals with significant language and developmental delays. All patients should be referred for specialized speech/language, occupational and physical therapy evaluations. 3. Neurological management. Individuals with PMS should be followed by a pediatric neurologist regularly to monitor motor development, coordination, and gait, as well as conditions that might be associated with hypotonia. Head circumference should be performed routinely up until 36 months. Given the high rate of seizure disorders reported in the literature in patients with PMS and its overall negative impact on development, an overnight video EEG should be considered early to rule out seizure activity. In addition, a baseline structural brain MRI should be considered to rule out the presence of structural abnormalities. 4. Nephrology. All patients should have a baseline renal and bladder ultrasonography, and avoiding cystourethrogram should be considered to rule out structural and functional abnormalities. Renal abnormalities are reported in up to 38% of patients with PMS. Vesicoureteral reflux, hydronephrosis, renal agenesis, dysplasic kidney, polycystic kidney, and recurrent urinary tract infections have all been reported in patients with PMS. 5. Cardiology. Congenital heart defects are reported in samples of children with PMS with varying frequency. The most common CHD include tricuspid valve regurgitation, atrial septal defects, and patent ductus arteriosus. Cardiac evaluation, including echocardiography and electrocardiogram, should be considered. 6. Gastroenterology. Gastrointestinal symptoms are common in individuals with PMS. Gastroesophageal reflux, constipation, diarrhea, and cyclic vomiting are frequently described. Table 3. Clinical assessment recommendations in Phelan-McDermid syndrome. Decipher database entry for 22q13 deletion syndrome, 22q13.org. Support group for families of children affected by the 22q13 deletion syndrome, Alliance 22. The true prevalence of PMS has not been determined. More than 1,200 people have been identified worldwide according the Phelan-McDermid Syndrome Foundation. However, it is believed to be underdiagnosed due to inadequate genetic testing and lack of specific clinical features. It is known to occur with equal frequency in males and females. Studies using chromosomal microarray for diagnosis indicate that at least 0.5% of cases of ASD can be explained by mutations or deletions in the SHANK3 gene. In addition, when ASD is associated with ID, SHANK3 mutations or deletions have been found in up to 2% of individuals. The first case of PMS was described in 1985 by Watt et al., who described a 14-year-old boy with severe intellectual disability, mild dysmorphic features and absent speech, which was associated with terminal loss of the distal arm of chromosome 22. In 1988, Phelan et al. Described a similar clinical presentation associated with a de novo deletion in 22q13.3. Subsequent cases were described in the following years with a similar clinical presentation. Felon et al. Compared 37 subjects with 22q13 deletions with features of 24 cases described in the literature, finding that the most common features were global developmental delay, absent or delayed speech and hypotonia. In 2001, Bonaglia et al. Described a case that associated the 22q13 deletion syndrome with a disruption of the SHANK3 gene. The following year, Anderlet et al. Refined the area in 22q13 presumably responsible for the common phenotypic presentation of the syndrome to a 100kb in 22q13.3. Out of the 3 genes affected, SHANK3 was identified as the critical gene due to its expression pattern and function. Wilson et al. Evaluated 56 patients with the clinical presentation of PMS, all of whom had a functional loss of 1 copy of the SHANK3 gene. However, later the same group demonstrated that loss of SHANK3 gene was not an essential requirement for the disorder.